All right. Well, welcome everybody to another live webinar from PALCUS on Facebook. We're happy to have our recurring guest, Dr. Joseph Amaral from Florida. Thank you so much, Dr. Amaral, for joining us again.
My pleasure.
If he ever starts charging us, Angela, we're going to have to be on a constant fundraiser to just to pay, a minimum fee.
No, you know what? I'm actually putting all this stuff into a book, so y'all can buy a book later, and
we will.
That'll be great.
We will. I will for sure, and I'll promote it as well.
That would be awesome. We'll
Thank you for doing this.
A book launch webinar, right?
Yes.
Exactly. Well, exactly. Yeah. There you go. You got it. I love it. Perfect.
So last time we were going to try and we talked about children and the COVID virus and schools opening, and we were hoping to get to vaccines, but we ran out of time. So today we're focused all about the vaccine and what's going on there, because people have so many questions. So I'm actually going to, I think I have to make you the host, Dr. Amaral, so you can share your screen. And so you're a host now, so go ahead and share away. And can't wait to hear what you're.
And we should tell folks if they have any questions to go ahead and send them to us, right? On Facebook.
Yeah, that would be awesome. And feel free to interrupt me on this one. As well, you can always interrupt me, but on this one, if you're getting questions, because this one is going to be a little bit more complicated, and I don't want to lose anybody.
Okay.
And there might be topics or things that I chose not to cover, so I'm happy to address any of those. So let's get started. So here we go. It's some time ago I wrote a post, did you get your shot? And so when we think of vaccines, we think about going to the doctor and getting a shot and crying and getting a lollipop. And one of the interesting things about vaccines is that typically vaccines are something we get as children. We do get the influenza vaccine as adults, but after those initial things, unless we're traveling somewhere, we really don't get a vaccine. We might get a booster shot, like for tetanus, and we'll talk a little bit about that. So as always, you can reach me at jfmaral.mac.com if you have any questions or you want to know something specific. So just to sort of refresh everybody's memory why we're doing this and what hasn't changed. We're now at pretty close to 6.5 million documented cases of COVID-19, at least through a positive test. That might be a good future topic, which is testing and what it all means and when to get it and what it, how to react to it. And we're rapidly approaching 200,000 deaths. I want to emphasize this idea of spaces that I put forward in the first webinar, and that pretty much most people would agree is the appropriate approach, which is wash your hands frequently with soap so that you destroy the virus. Make sure you're physically distancing at 6 feet. This concept is confusing. People think they can physically distance by 6 feet and not wear a mask. All these things are done together. Individually, none of them are, effective. Or they're all effective, but they're not as effective as they would be if you use them all together. You really need to avoid indoor spaces and crowds of people because you never know who's going to have it. And the issue here is that obviously if you walk into somebody who's, sneezing and sniffling, well, you're going to stay away from them. But it's this low or pre-symptomatic patients, people who have COVID, who are going to develop symptoms, but don't have any symptoms yet, that typically are those that spread the disease. Cover your face, wear a face mask. I'm noticing, I don't go out much, but when I do, I'm noticing that people are starting to be a little bit less diligent in wearing face masks. It's important. It is at least a 65% protection for you. Enjoyed the outdoors. So we had Labor Day weekend, and I hope everybody, did enjoy the outdoors. That doesn't mean go to a crowded beach with 60,000 people. And then, make sure you know who your circle is, who your social bubble is. So none of that has changed. But in order to move forward, then, we need to, in talking about vaccines, we really need to focus a little bit on what is immunity and how do vaccines work. And so there's a little bit of complexity in the beginning, because what I think I see is that most people don't really understand the complexity of the immunology. Frankly, it's so complicated. I can only get so far. And so there's a lot of confusion. So we all probably know the story. The first vaccine for a virus was actually created in 1798. And it was Edward Jenner, and it was the smallpox. He had noticed that milkmaids who were taking care of cows and milking the cows wouldn't get smallpox. And the cows got a disease called cowpox, which was similar to smallpox. And he thought, wow, what if I infect somebody with cowpox? That will protect them from getting smallpox. I mean, this is before anybody even knew what an antibody was or a T cell. Well, he did something rather remarkable. He convinced his gardener to let him vaccinate his son and then infect him with smallpox. That's called a challenge trial. And today, many people believe they're unethical. If we have time, we'll talk about it. I think it's not. I think it would be a good idea for COVID. But essentially, then the child did great. He was still nervous, waited a few more weeks, then he did 12 kids. Now, the big point I want to make here is that it took from 1798 to 1977 to eradicate smallpox. It's quite a long period of time. Since we've eradicated that disease, roughly the United States put into the global effort $36 million, and it's calculated that every 30 days we are saved $36 million since smallpox was eradicated on the basis of time out of work, healthcare, sickness, etc. The other vaccine that's really well known for everybody is the polio vaccine. Everybody, if you're my age, you remember lining up in some queue to either get a shot or cubes. You also might remember what's called the Cutter incident, which was certainly after the polio vaccine was proven in literally hundreds of thousands of children. There was a manufacturing problem, and a whole bunch of children got polio, which created a huge panic. So polio vaccine has been available since the 1950s in one of two forms, either an oral form or an injection. And as of today, there's 2 strains have been eliminated, but one still exists. And the third is measles. And measles is still not eliminated, and every year, it was thought to be eliminated in the year 2000 in the United States, and then in 2001, there were like 60 cases. So it's very difficult to eliminate a virus. And in order to eliminate that virus, there are certain things that have to be true, of which that seems not to be the case for SARS-CoV-2, the virus for COVID-19. And the one characteristic that you need to have is that the virus only exists in humans. If there's an animal reservoir for that virus, then you can't go and infect all the animals, vaccinate all the animals in the world. So there's always going to be a risk. So eradicating a virus means that virus is no longer on the face of the earth. So we really aren't going to eradicate COVID-19 or SARS-CoV-2. What we can do is control its epidemic spread. Now, many people have the mistaken belief that there's going to be a vaccine delivered and all of a sudden everything's going to be fine. That's not the point of a vaccine. What a vaccine will do is protect a certain percentage of the population. If more than 70% of a population is protected, and that percentage depends on the infectivity of the virus. So for example, measles, you need 90%. Influenza, you probably need around 60% or 70%. And so most estimates are you need somewhere around 70% of the population to be immune. What that does is, doesn't make the disease go away. It stops the disease from having surges or epidemics. So like you see today, college opens its doors and 1,000 students at the University of Alabama have COVID. That won't happen because there'll be a separation between people, But the reality is, if you're not vaccinated or you're not immune and you happen to get next to one of the 30% who aren't immune and have it, you'll get it. So the idea that all of a sudden, once we get a vaccine out, all the restrictions are going to go away is erroneous. We will continue to need to be vigilant to some extent. The second point of confusion is that people believe that if they get a vaccine, they get antibodies, and they get antibodies, and then all of a sudden they're immune. Well, having antibodies and having immunity are two different things. You have to have the right kind of antibodies, you have to have the right amount of antibodies, and even if you have antibodies, you still might get some degree of sickness. Usually it's minor. You've seen that in the past couple of weeks. There have been reports of people who have gotten a second infection, almost always milder than the first, because the way it works is the antibodies will eventually go away to low levels, sit in our memory of our white cells, and I'll go into more detail. The other issue is that for SARS-CoV, we don't know with any degree of certainty what the duration is of immunity or how much immunity you get. It does appear fairly certain today that the sicker you are at your first encounter with the virus, the more immunity you get if you survive. And that makes sense. The sicker you are, the harder your body fights, the more antibodies and T cells are going to be made. Every vaccine currently in phase 3 requires 2 doses. And that's the concept of the first dose and the booster dose. So if we go back to what I just said, the first dose is sort of the mild infection, and I get another one, which makes it a stronger infection, and I get a stronger response. So what everybody making vaccines is doing is checking the immunity of antibodies and T cells formed versus that seen in patients who have had COVID and recovered. What the studies all show is that in general, the amount of antibodies and T cell response is 2 to 3 times that of those recovered patients. And that's a really good thing. However, the group of antibodies and T cells in that recovered group of patients comes from patients who are mild and severe. In some of the studies, they were mostly mild, not severe. So it's still not clear what that is. So there are risks then to really stopping this pandemic at some point simply on the basis of a vaccine. And the first is that today, 30 to 50% of Americans are saying they're not going to take it. And there are a lot of reasons why, and the most important reason is the process of developing this vaccine has led to a lack of confidence. It's interesting because this is not based on the anti-vaccination group of people. These are people who believe in the vaccines and they don't have confidence. And there are many reasons why. I'll probably sprinkle them into my talk as I go. But one of the main objections is the speed. I got to say, I'm less concerned about with the speed of developing a vaccine. I'm concerned with the speed of testing it and proving it over time. And those things, which I'll spend time on, do require a certain amount of time. A vaccine to be effective needs to be somewhere around 50 to 70% effective. What does that mean? This is a point of confusion for people. They say, well, it's 50 to 70% effective. So it makes it sound like I'm going to be 50% less sick. That's not what it means. What it means is it works in 50% of the people. So if I have 100 people who get vaccinated and 100 people who don't get vaccinated, and the vaccine is 50% effective, I would expect 10 people in the vaccinated group to get an infection and 20 people in the non-infected group. That's the way the vaccine is being determined for efficacy. And we'll talk about that in a minute. So it's very similar to the influenza vaccine. The influenza vaccine typically has between a 45 to 60% efficacy rate. What that means is that 35 to 50% of people will still get the flu. Those are the ones that got the vaccine. And either that specific virus that they got infected with isn't covered, or they didn't build up enough of an immune response. And we'll talk about the reasons why. These vaccines require complicated manufacturing and storage. So you have to have the capacity. And the United States has done a great job of setting up early the manufacturing capabilities to build them. But depending on the type of vaccine that's made, it can take a longer or shorter period of time. But in the case of the vaccines that are being tested, they all have one very specific problem. They need to be stored at below 0 temperature. So distributing these vaccines will cause a degree of difficulty in terms of getting it into all the areas that you need to get to. When we think about this also, it's great to think about the United States, but if you do the United States and you don't do everybody else, you still don't have freedom to move. And the last, of course, is the duration of protection. As you know, you have to get an influenza vaccine every year. In the case of the influenza vaccine, partly it's because the immunity goes away, but more importantly, it's because the virus changes. In this particular case, we hear a lot about there are 7 types of viruses or 20 strains. That's an improper use of the term. In order for it to be a strain, considered a strain and different, it either needs to be immunologically different, that is, the body doesn't respond to it, the immune response the same. It needs to be resistant to drugs. It needs to be more infective. And there's a 4th one I'm forgetting. So it does look like there are 2 strains of the virus. One that, and the one more that we currently seem to have floating around, G812, is the one that seems to be more infective. But no one has been able to document that there's any degree of difference in how sick it makes you, whether it's resistant to drugs, whether it produces a different immune response. And the chances are it probably doesn't. So these are all open questions. So let's talk now about your immune response. Your skin, your hair, the nose hairs, the mucus in your GI tract, those are all part of your immune system. They're all the natural barriers that we have to prevent things from the outside from entering our body. They play a very important role. So the first thing we do is to try to trap these things from entering us. You know, the body is kind of interesting. We think of ourselves as solid, but we're not. We're a tube which goes from our mouth through our esophagus down and out our anus. And so we're exposed not only on the inside, but on the outside to all these agents. And so, for example, if you were to inhale a virus, the virus will get trapped in your nasal hair and then in mucus. And in the mucus of our nose and in our sinuses are cells, T cells, that will destroy it. So we have active immunity and passive immunity. Passive immunity is the immunity that we have shortly after we're born and we receive antibodies from our mother. So her antibodies are present and they go away in about 6 months. And that's natural transferred passive immunity. There's also acquired immunity. And we heard a lot about that a couple of weeks ago, which has added to the concern about safety of vaccines with the plasma convalescent therapy. And I'll talk about that at the end. But we can give people antibodies, and it's used to treat rabies and a whole host of illnesses, either in 2 forms, either in plasma, where they're not well documented, or we make them, called monoclonal antibodies. Those usually last about 6 months. So we can actually have a treatment based on immunity, which is different than a vaccine. On the left, then we have active immunity. So when we're exposed to this virus, we're going to have 2 processes that go on. The first is called innate. Innate being, it's something we have, it's non-specific, and it's just a generalized reaction. So think about that as if you were in a battle that you you send in airplanes and start carpet bombing everything. That's innate immunity. There's no specificity on the target. It identifies something as foreign and it starts shooting. And that comes from our T cells. So T cells are white cells. We have many different types, but two of these are called T cells and B cells. The adaptive immunity is the second part of immunity. And in that immunity, there is some T cell adaptation immunity where T cells become more recognizing of the foreign antigen. But most importantly, that's where we form antibodies. So what happens is the T cells recognize this foreign product, send a signal that brings B cells into the area, and those B cells then manufacture antibodies. So two types of active immunity, innate and adaptive. The adaptive immunity is like sending laser-guided heat-seeking missiles. So they're only going to hit and destroy the virus. In the innate immunity, they'll destroy the virus and anything else that's around it. And part of that's what you see in this concept of a cytokine storm. It's just a super revved up inflammatory reaction. Is that clear? So there are many types of T cells, but there are two types of T cells that are really important. The CD8, and those are the cells that kill cells. And the CD4. Some of you might remember the term CD4 because HIV depletes our body's CD4 cells. And then that's why you can no longer fight infection and you become immunocompromised. B cells make antibodies. So there are two really important cellular components to our immune system. And either one of these can be sufficient to take care of an infection, either T cell or B cell. An antigen is a pretty cool thing. It generally has a very fixed heavy chain, which is this part here. And then it's a Y. And then it has these receptors or light chains that allow the antibody to connect with an antigen. So it's a lock and key. Think about it as your lock, which is the lock is the antigen, I'm sorry, the antibody, and the key is the antigen. And so when these two things match, they stick together and it traps that antigen. So the virus is sitting there surrounded with these proteins sticking out that have a shape, and those shapes then fit into the key. The discovery of this was a Nobel Prize winning by Paul Ehrlich in around 1908. But there are many types of antibodies. The typical antibodies we have are the IgG and the IgM, which are the generalized ones. But within our GI tract and within our respiratory tract, we also have IgAs and IgEs, different kinds of antibodies in their molecular structure. And so these are all important in getting rid of a viral or bacterial infection. So once this antigen, bacteria or virus, is sitting around, we have the exclusions are our virus and the capsules are our bacteria. They fit in here. The antibodies will bind to them, and then the T cells will eat them up. So B cells are making the antibodies, they stick and neutralize it, and they get eaten by the T cells. There's a very specific kind of antibody called a neutralizing antibody. So all the antibodies that are being made to specific areas that are seen as foreign on a virus or bacteria. But it doesn't mean that that specific antibody has the ability to protect the, sorry, somebody rang the door, now my dogs are barking. This should be interesting. I'm gonna mute. here's the virus, and then what's going, so here's the virus, then it can attach to the receptor. Once it gets inside, then if there's no neutralization, it will be able to be taken into the cell and replicate. But if these antibodies stick, it will stop it from either being in the receptor and then the receptor from moving the molecule or the virus into the cell. And then it can also stop the virus from uncoating and opening up to release its genetic material. And it can also form clumps. So that's what your IgM does. So neutralizing antibodies are the ones that are most important and the ones that we really want to know patients have. And all studies to date show that patients following, that 90% or more of patients following a COVID-19 infection do develop neutralizing antibodies. So the killer T cells that we talked about, part of the T cell response, they also will recognize receptors, and they will also be able to bring in antigens, and they will be able to kill the bacteria by releasing these things called cytokines that we've heard so much about. Interestingly, during the course of the pandemic, we've learned that 30% of people in America, actually in other countries, have memory to a T cell. Our T cells have memory to a COVID virus that seems to be able to kill SARS-CoV-2. So there is a natural degree of immunity probably present in about 30% of the population from having been exposed to coronaviruses. Coronaviruses are a very common cause of the cold. They're the second most common cause of a common cold. And that can explain some of the differences also why some countries see more COVID-19 and some see less. And, you know, we can conjecture and make it all up. But the bottom line is there's some degree probably of immunity that people have. And that might explain also why some people are more likely to get sick and some people aren't. But it's more complicated than that. So this comes from the CD8 cells. So here is just a graph to show you that people who get a mild infection will get a T cell reaction, but it's not as strong as if it's severe, which you see in the second. You also see that when it's severe, there are a lot more of these cytokines, these ORF6 and ORF3, all these molecules being released. And it's these molecules that are believed to create a problem. We know that once you get infected, you do get a response, and that response is it's at about, I think it's 15 days. After 15 days, it plateaus and will remain at that level. We know this now is true for about 4 months. We don't know how much longer. And studies done historically suggest that the immunity wanes with time, but it doesn't completely go away. So in the end then, when we think about giving somebody a vaccine, we're really talking about activating T cells and B cells. It's not just about antibodies. And that's why you see people reporting and measuring T cell responses and antibodies. We need to have the right antibodies, neutralizing. So simply because somebody has antibody levels that are higher than normal or specific to the virus doesn't mean it's going to kill it. So this question of an immune response and being immune to the virus are very important. There was a study published last week in the New England Journal of Medicine done in Iceland that did show that patients maintain an antibody response for up to 4 months. So that's good news. So we kind of have an idea that there's a likelihood that if you get antibodies, that they're going to last for 4 months, and if they're neutralizing, you'll have some degree of protection. Now, if we're going to build a vaccine, then the vaccine has to have the antigen, that molecule that's recognized as being foreign. And currently, there are two types of vaccines made in groups. One is the sort of traditional vaccine where you take a virus and you either make it the same virus, but make it unable, you weaken it to the point where it won't cause a significant infection, which is an attenuated virus vaccine. There's a polio one like that. Or you inactivate it. And when you inactivate it, you take the virus and you treat it with some chemicals so that you destroy it in some way so that it can't replicate once it gets in the cell. So the attenuated virus is done by taking the virus and you keep on infecting cells, and eventually you get to the point where, or you can change it genetically. So influenza viruses, respiratory syncytial virus, there's a whole, measles, there's a whole host. The traditional lane for vaccine development has been using either attenuated or inactivated virus, the virus itself that causes the illness. There are risks and there are some problems. So typically attenuated or inactivated vaccines require 2 doses. If you go get an influenza vaccine, it's actually done in a different way, which is you can get a small dose or high dose, but they're difficult to manufacture. They're often manufactured in eggs. So there's like protected chicken farms making eggs in the United States. I already said they usually require 2 doses. And they're difficult to purify. Basically, you have to infect the chicken egg. The virus grows in the chicken egg. Then you have to harvest it, clean it up, get just the virus, create, there's a lot of steps. So the more promising approach to this more recently has been to use more genetic methods where you inject either RNA, DNA, or the protein itself, and you push it into the patient, and then you get an immune response. I put 150. There are now estimated to be over 320 vaccines in development. And you say, wow, that's a lot. It is a lot, but as you'll see in a later slide, only 5% of vaccines that start at the beginning ever get to the end. So you need to have a lot. There currently are 8, though, that are in the works. So we have the traditional vaccines, and there's 2 that are being developed, and they're both in China, Sinopharma and Sinovac, and they're both using an inactivated virus. The Sinovac vaccine, called Coronavax, has recently been in the news because despite not having been approved, the company actually vaccinated their employees and families, which to me sounds pretty unethical. On the other end, we have these genetic-based approaches, and I'm not going to spend a lot of time going into the detail. I will say this, that of the ones listed here, they are all RNA-based vaccines. So what I can tell you is that there has never been an RNA or DNA-based vaccine approved for use in man. And that's one of the reasons there's concerns about the safety, because it's never been done before. On the other hand, you got to do something first to get there. So we'll put that aside. There is a DNA vaccine that's been approved for animals. So we do have some experience. Now, these break up into a few groups. So the Oxford and the Oxford AstraZeneca and the J&J vaccine are using a method that has been used, and there are approved vaccines using this method. So what you do is you make a virus, make the protein that causes the antigenicity against SARS-CoV-2. So the Oxford, the J&J, and the CanSino Bio. So what they do is they take what's called an adenovirus, which causes the common cold. They genetically modify it so that it will make the protein that triggers the immune response against SARS-CoV-2. You infect the person with the adenovirus, and then the person develops a response to SARS-CoV-2. Got it? The fundamental difference between these three companies is Oxford is using a chimpanzee virus. J&J and CanSino Bio, which is a Chinese company, this is Johnson & Johnson. The latter two are using a human adenovirus. So this is a virus that we get that causes the common cold. And some people say, well, I'd rather get a human virus than a chimp virus. But what is the concern is that if you've been exposed to that adenovirus, to that cold virus, you may kill the virus before it gets to form an immune reaction to the coronavirus. The Oxford virus uses a chimpanzee virus, and the virus doesn't cause a cold. It's inactivated for that part. So those methods there's more experience. J&J, for example, has an Ebola virus that's been approved using this methodology, and they used a human virus. But those are small groups of people. You don't vaccinate the world against Ebola. So Oxford, J&J, CanSino Bio, it's an RNA. It's an adenovirus-based vaccine where a protein is being developed. Pfizer and Moderna, Moderna being the vaccine that's being sponsored in conjunction with the National Institutes of Health. These two companies are manufacturing a vaccine using messenger RNA. So they basically inject messenger RNA into you, and it gets into the cells, and the cells manufacture the protein, and then the protein creates an antibody response. As I said, those have never been tested. But to date, the results look good. You've heard a lot about the Gamaleya or Sputnik 5, which is the Russian vaccine. It was developed and is similar also to Oxford. And basically, it uses an adenovirus. They tested it in, I believe, 76 patients and then approved it for general use. They've gotten a lot of pushback, and currently they're doing a phase 3 trial. They will release it next month, and we'll see where it goes. But the results were published last week, and it did develop an immune response and seemed to be relatively safe. So there are many types of vaccines. These are in China, and I would say it's unlikely we're going to see them here. Doesn't seem like we're the best friends with China right now. But more importantly, they're not necessarily following the regulatory path that we need in order to approve a vaccine for use, or even for an EUA, which I'll get to. And the ones you're going to likely see are going to either be the J&J, the Moderna, the Pfizer, or the Oxford. J&J is in phase 2, soon to start phase 3, and this is in phase 3. So what are all these phases? So first you have to develop a vaccine. You have to sit down on a piece of paper. You have to figure it all out. And then you go design it, and you test it. You test it in cells. You test it in animals, and that's the preclinical testing. So you have some degree of understanding that this will work. You then take that and you enter into a phase 1 trial. In a phase 1 trial, you give the vaccine to 20 or 30 healthy volunteers, and you look for safety. You just want to make sure nothing bad happens. And all vaccines are going to cause some degree of bad. You're going to get some fever, some muscle aches, some headaches, because those are the general reactions to an immune response. In fact, it's good that you get that, because that tells you you're developing an immunologic reaction. Fever and all those muscle aches, they actually come from our response. They don't come from the virus. Then you take it and you give it to thousands of patients. And now you're looking for safety again as your primary endpoint. But you also now measure, did they get a response? What's been done to accelerate vaccine development is most companies have combined phase 1 and phase 2. So that's one of the ways they've accelerated it. And they haven't done thousands of patients, but they've done hundreds of patients. And they're still publishing data as you go along. 2 weeks ago, there was data published from the Pfizer phase 1 and 2 trial. Now, once you know that it's safe in a small number of people, well, now you got to test it in a big number of people because there's so much genetic diversity and human heterogeneity. So we then want to have tens of thousands of patients. Some vaccines, like polio, were tested on 1 million patients. Then once the vaccine is released, there's a phase 4, which is where there's surveillance, and everybody who gets it is monitored. So to give you an idea of making something fast and why people get nervous, this is all the steps. It's a big, complicated process that involves thousands and thousands and thousands of people. If a vaccine enters human studies, it has a 33% chance it will be approved. So today, if there's 8 vaccines in clinical trial, we would expect that only 2 would make it. Is that right? 6. If there were 6 in clinical trial, we would expect that only 2 would make it. So you need to have a number of these in the pipeline. From the beginning, when you start to think about it, to the end, it's 5%. So why can we do this so quickly? Well, we've had a lot of experience with SARS. So this is just a variant of SARS. So we're able to leverage what we already know. And we've had a lot of good experience with not only SARS, but with Ebola and dengue and other viruses. So it's not remarkable to me that you can get into the clinical trial that quickly and that people can design these. Because currently they already have, off-the-shelf vehicles to deliver these. Think about it like when you go to the paint store. You want red paint, but the base color is already there. You just add the red ink, and that's basically what they're doing. All the detail and delay is on this side. And some of this is government bureaucracy, and some of it is actually necessary for safety. So you can speed this up for sure and be safe. So the FDA has a proven criteria. It needs to be safe. Safe doesn't mean that you don't get a fever, you don't get a headache. Safe means, nobody's dying or nobody's really getting sick and needing to be hospitalized, which is, they're called SAEs, or serious adverse events. So you have to have a really low serious adverse event. I want everybody to know, when a vaccine gets distributed, people are going to start having all sorts of weird complaints and symptoms, because that's just the way it works. Some of those will be real, some of those won't. Well, they'll be real symptoms, they'll just either really be related or not. It needs to be effective in at least 50% of people. Some would argue that's a pretty low bar. It's what we use for influenza. So 50% is better than nothing, so that's good. In order to be approved, this is to approve a vaccine for long-term use, you need to have a 30,000 patient study. Now that seems like a small number to me, but it's a pretty large number of patients. But remember that a 30,000 patient study means 15,000 patients get the vaccine and 15,000 don't get the vaccine. They're the control. You have to have a representative population above 18 years of age, and you have to have all races and all ages. And we'll see why that's important. And then finally, you need to have 6 months of follow-up. Now, a little diversion. A primary endpoint is what the study is calculated to measure. A secondary endpoint is something you measure, but you don't have the certainty statistically that it's true. In this particular case, the endpoint is efficacy and it's less infections. So it will take time after you got vaccinated to determine whether those vaccinated got infected less than those that didn't. And we have an additional problem, which is that we have to be concerned about what kind of restrictions people are using in both groups. So lots of people have been talking about the October surprise and that there will be a vaccine ready prior to the election, and that it's a means to generate votes. Personally, I find that unlikely. Why? You have to get 2 doses. They have to be 21 to 28 days apart. You can only measure antibodies 28 days after the second. Well, you will measure antibodies after the second dose. Then you have to follow them to see if they get infected. The study started at the end of August, so it's hard to imagine how you could ever get to enough patients to be able to make any assessment. Currently, Moderna has 71% enrolled, Pfizer 66%. So let's say they finish by the end of September, you still then have to wait another 28 days, which puts you at the end of October, at the end of October. And that's just to get everybody vaccinated. There are 2 ways, however, that you can expedite that. And one is called emergency use authorization, where the FDA says, we have enough data, so many people are getting sick and dying, we're going to release this. And there's been a lot of concern that the FDA would do that. The FDA has recently said they wouldn't approve one that's not safe and effective, but there's not a lot of trust right now in the FDA because of the convalescent plasma problem. But what most people don't know is there's a way you can approve a vaccine that doesn't require the FDA. You bypass it. If the Department of Health and Human Services decides that it wants the vaccine, it can approve it. But to do so, the companies have to submit the information. So the likelihood that that will happen is now approaching 0. And the reason is that last week, the manufacturers of these vaccines said they will not submit the paperwork, which is submit the EUA paperwork, unless there is substantial evidence of safety and efficacy, which seems improbable to be able to be achieved by the end of November. So everybody's trying to ensure that people have confidence. And for me, this is a really important statement because it means if those companies feel that way, having worked in one, generally they're going to truly believe in safety and the efficacy of it. So there are risks, and what makes this more problematic and why that getting to 70% and why not everybody who has antibodies is immune relates to obese people react differently. And 35% of the American population is obese. And it's not clear why obesity impairs immunity, but it does. Elderly people do not get a good immune response to a vaccine. That's why if you're over 65 and you go get the influenza, ask for the heavy dose, the big dose. And it's because they lose the T cells that I talked about. It's not an indefinite supply. Children under 18 generally do respond well, but they need to be tested. So in this case, we're not testing anybody. They're not going to be able to be vaccinated. And you always have to worry about the impact of vaccines in pregnancy. So pregnant women really won't be able to be vaccinated initially. But race is also important. Blacks, African Americans, Latino X, they're all going to react differently. And they all have different degrees of obesity associated with them. So these groups need to be understood. It's less about safety and more, you don't want to go vaccinate a bunch of people, tell them they got vaccinated, and then they go get sick. The safety issues are a little bit less concern for me in terms of, you're going to get fever, aches, pains, all that. There are unusual and rare side effects or adverse events that we do need to worry about. So Guillain-Barré is something that was believed to have happened with the avian flu vaccine in 1976, subsequently probably proven not to be the case. And that's a neurologic disorder which usually resolves. And these two are unusual things. They've happened with both RNA, DNA, and with traditional vaccines. I'm not going to talk about them. These have not been reported. So the last is that we can deliver antibodies directly as a treatment. And I do think this is equally important to a vaccine. And combining vaccines with treatment are what will end this the fastest and get us back to normal. In other words, if you have a treatment that will take care of you if you get sick, and you have a way to prevent you from getting sick, you're covering yourself quite well. And then I think restrictions can go away. The monoclonal antibodies are manufactured. They're currently in clinical trials, don't know any results. plasma convalescent therapy, I just gotta say it, there's no evidence to date that it does anything. We did approve it, but there's no evidence that it's of any efficacy. But the important thing is they resolve. So in conclusion then, I think it's progressing rapidly. It's got positive signs. We always should have a degree of concern, but we shouldn't be overly concerned at the moment that, you know, something bad's going to happen. I think the earliest we're going to see any kind of widespread distribution other than to some very special subgroups is going to be at the end of the first quarter of next year. And people should look to monoclonal antibodies as being just as important as vaccines. Thank you.
So we do have a couple questions. So that was really detailed, and I feel like I learned about vaccines in general, which, you know, I think is always important given the scrutiny. So this one gentleman said, I survived COVID this August. My doctor told me that I should get vaccinated because the virus can be the base to other sicknesses.
The virus can be the base to other sicknesses.
Maybe it makes him more susceptible to getting other illnesses, or I mean,
okay,
you can get it again, right? You don't become immune.
So that question has two components, and so to the person who's listening, my recommendation is, so there's a thing called vaccine-associated enhanced respiratory disease. Antibody-dependent enhancement. And that's where you got a vaccine to a virus, and then when you got the virus, you actually got sicker. It happened with dengue fever, and it also was part of a problem with SARS. So I think in this particular gentleman's case, I can't make a recommendation until I know the data. And because in the data, they will be looking at people who already had COVID and what happened to them. So frankly, I think it's too early for somebody to say, if you've had it, you should go get it, until we know that there's no problem in patients who've gotten it. To date, this has only been tested in people who've never had it. In the trial, there are people who have had it. So I hate to disagree with the advice, but I think I'm not sure that's sound. The second point is that if you get vaccinated, there is some evidence that you get protection against other viruses for some period of time. And this was originally discovered with the polio vaccine. And it's because you rev up your inflammatory immune system initially with the vaccine, and you have that non-specific stuff. So the idea that if you get a vaccine, it will protect you potentially against others is reasonable. But I would be concerned about, if I've had it, running off to get a vaccine unless I know that people who've had it have done fine with the vaccine. And that is part of the study. It was a very interesting question. So that answers that one. You got another one? You're reading a question. Oh, you can't hear me.
Okay, can you hear me?
Yeah.
Earbuds are having issues today.
Yeah.
So we have another question, and it's not necessarily about vaccine, but it's about a second wave. Is Europe, like Spain and France, et cetera, under a second wave of COVID?
You know, that's another really interesting question. I was actually thinking about that this weekend, and I think somewhere I might have written in one of my essays about that. You know, the idea of a first wave and a second wave is that the first wave is separated by a period of time, and typically can be a change in the virus, or it can be seasonal. So in the case of it, you know, we're talking about this first wave, second wave related to influenza, which is a seasonal virus. So in this case, we don't have that. You know, it doesn't look very much like SARS-CoV is tremendously seasonal, although people have related it to humidity and temperature in some degree. I have some difficulty understanding that because they say when the humidity is high, the virus isn't as infective, yet you look at Florida, which surged in the summer when the humidity was high, and the same in California, right? You guys, the people in California got it. So I think it has more to do with physical activity and all the elements of crowding and all that, but that's an opinion. As far as whether to call it a second wave or a surge, when I look at all the data for Europe, all those countries came back down to pretty much really low levels, less than 100 cases, less than 200 cases. And now they've gone up. And I'm not willing to conjecture if it's truly a second wave or just the same wave and it's come back, but it certainly looks like a second wave. France continues to rise. The UK is starting to rise. And Spain, obviously, well, Spain is starting to come down. I actually didn't recently track Portugal, so my mistake. I track a group of countries every week, which are Italy, France, Germany, the United Kingdom, Belgium, and Spain. And those 6 countries are equal to the population of the United States. So the density of those countries is actually greater than the United States. And so it's somewhat remarkable. The United States is averaging around, the numbers in yesterday's thing, I think the United States is averaging 45,000 cases a week in the UK, and the Europeans are averaging 15,000. We also are averaging, our death rate has dropped. So last week, it's been averaging 1,000, and there are days where there are 1,000 or more, but the calculation for the last week was about 750 deaths per day. Europe is averaging 98 deaths per day, but they're now starting to see this increase. So their death rate will be lower later. So I don't know whether to really call it a second wave, or it's somewhat of what happened in the United States. In the United States is an interesting observation also. When influenza in 1918 came, it first was in the East Coast, and then I think it went to the West Coast, and then it went to the South, and then it went to the Midwest. These things don't just move in a straight line. And we've kind of seen that now. You had New England, the Northeast was hammered. Then it was the South and West. And now the epicenter, not the epicenter, but the biggest amount of illness is in the Midwest. And people, you can attribute that to colleges and universities, but colleges and universities are everywhere. So it's, there's just so much we don't understand. If I was pushed, I'd say, yeah, it's a second wave, but I don't really know. It's a guess, a lot of guessing.
So we are coming up on our time, but just going back to the vaccine issue in general. So in your estimation, there likely will not be a vaccine available in the US before the election. We probably,
yeah, my guess.
There's always the possibility it will, but your estimation is that probably not.
Well, yeah. So it's funny because if the pharmaceutical companies hadn't said that, if you've been reading along what I wrote, right, I would guess that it is. The president is completely focused on getting a vaccine before the election. And there are ways to make that. But what the group from the pharmaceutical industry suggests is that they're going to take politics out of this, because they recognize that if they let politics in the middle, it's actually not going to be beneficial to getting people vaccinated.
Sure.
So my hedge is no, you won't see it beforehand. But the government is focused on getting the delivery mechanisms and everything in place before the election. So we'll see.
But Mike,
I don't like making predictions, right. So you can tell.
In medicine, you don't, obviously, huh? But Dr. Amaral, my concern is, even if something is announced, for political reasons, obviously, but if something is announced, will there be enough confidence? Because you've shown there that there's a certain percentage of people that, will not even take the vaccine, regardless. So will it have any effect at all? Because if people are
so I think that's a better question. So that's a better question, Denise. Even if this is available, like they can announce whatever they want, right? But even if it is available, so just imagine how complicated this process is. I got to get the vaccine to the locations. I need to have needles, syringes, masks, gloves, swabs. If there's 300 million people, I need at least 600 million of everything. I need to have people. I need to train people. So what is likely to happen in the plan and it's interesting because there's two conflicting plans right now. So the CDC's plan is they're going to initially vaccinate healthcare workers and high-risk people. It hasn't worked out so well in Russia, incidentally, because they wanted to vaccinate healthcare workers and high-risk people, and they're all saying no, to Denise's point. But more importantly, from a political purpose, you can vaccinate 20 people and say, hey, we vaccinated 20 people, and that accomplishes their objective. That's why I always get nervous. But it's going to take a long time. And we shouldn't expect to have a vaccine have an impact in the United States until at earliest the middle of next year. I mean, look at how hard it's been to get everybody tested or to test. Now think about vaccine, people's hesitancies and reticenceness. And, there's going to be people that are going to say, yeah, let Johnny down the street go get it. I'll see how he does before I go get it. So that's why I keep trying to get people to understand the best thing you can do is to follow the rules and get this thing under control. And because then you also make it much easier for the vaccine to be helpful. So I'm not a herd immunity guy.
I know we're almost out of time, Angela, but I just have to ask this because of the numbers, Dr. Amaral, if you'll be kind enough to answer this part, because of what you just mentioned now, get this thing under control. I just recently read a few things, and Dr. Fauci just had an interview not too long ago, and he was saying that to him, he'd like to see 10,000 or under per day. We haven't been able to get down under 40,000 forever. I mean, we'll get, one day here and there that we'll get 37,000 and we're back up to 50,000. So is this thing even under any kind of control at 40,000 plus?
Yeah. So no, the answer is no. Control is relative, right?
That's true. That's true.
So if you go and look at July when we were averaging 70,000 and now we're at 40,000, we're pretty good. And it's interesting because Europe is going up. You see a little bit in Asia, but most of the world is going down other than India. Brazil's cases are going down also and deaths. Now, I don't know how reliable those numbers are. And I would defer to Dr. Fauci on the 10,000 number. The idea is simple, though. The less number of people that have it, the less likely it is for people to come in contact with those who have it. I mean, America is a huge country. So is it better control than it was in July? Sure. But I think that we have a series of events that are going to tell us what's going to happen in the next month. I'm not making a prediction. You've had all these universities open up. Now, the students seem to be doing okay. And we know that students typically don't get sick, but students do carry the virus. The universities have been told to keep kids at school. The universities are sending kids home. I actually understand their viewpoint as well, right? Like, why are we keeping them here? So I understand both viewpoints. If universities is creating a problem, schools haven't done so well with kids, and they are spreaders. You have Labor Day weekend, and you've had a series of big high-profile events where people have gotten. You had the Sturgis motorcycle event. You've had the one that was most remarkable to me was the Republican National Convention on the White House lawn, where nobody's socially distancing or wearing masks. Those people leave those places and they scatter all over the United States. And then it's just a series of collisions. One person comes into two come into four come into eight. So I think we will know a lot in the next 2 months as to whether we're controlling this or not. But right now, I certainly agree with Dr. Fauci. We're not doing as well as we need to do in order to be like countries like Germany or Asia. On the other hand, if you look at France, I don't know what their numbers were. It's like 6,000, 7,000, 8,000. That's a lot of patients, right? If you take that number and put it in the U.S., that's a significant number. So I don't think we're doing as poorly as we were before. I don't feel like we're the leper of the world anymore. And I think there's a lot we don't understand. But the better is get it down. And it will make a vaccine, in my mind, be better too. So it's all good. All right.
Thank you.
Anything else? No, you're welcome.
I think we've gone over, but that's okay, right? Well, thank you so much.
They stay on or they don't. Thank you.
Well, thank you. I know Angela's having some sound issues, so thank you, Dr. Amaral. Thank you, Angela. Thank you all. Thanks to everybody on social media. And of course, this is being recorded. We'll have a part of our PALCUS podcasts. And again, thank you, Dr. Amaral. We appreciate it so much.
My
Take
pleasure.
care.
Thank you.
Thank you all. Take care. Bye-bye.
Yeah, bye-bye.
Bye-bye, everyone.